Catherine. And Michael, you certainly gave us a lot to think about. I like the fact that you are excited by the new innovations that we can expect. And I think if we all, work together, we certainly can affect change right across the country. Now, our next speaker will dive even deeper into the key recommendation learnings from the fourth wave. It is my pleasure, you can see him on the screen now, to welcome Will Falk, Executive in Residence at the University of Toronto, Rotman School of Management, Senior Fellow at C.D. Howe Institute, and Innovation Fellow at Women's College Hospital. I hope you're well, Will. Welcome to the stage.
Thank you, Suanna. I appreciate you having me here, and appreciate Michael and the team having me. I am going to speak through a report that I prepared at the request of Health Canada for the federal and provincial virtual care table earlier this year. If I could have my slides, please. The report's available on the QR code on the right, and this talk is available on my Twitter and LinkedIn feeds. I have not been on the front lines of the pandemic. I've been in the rear echelon. Zach, you're going to need to move the slides. I've been in the rear echelon during the pandemic, and I guess the first thing I'd like to do is to acknowledge the incredible people who have been working so hard during this pandemic. During the pandemic, as a rear echelon person, I have had the chance to work for various federal groups on 3 reports, one on long-term care, the one I'm going to talk today about virtual care, and one on resiliency. And I've just been overwhelmed by the stories that I've been hearing from people living through the last 2 years. During the course of this report, which was released in both English and French in August, I had the chance to talk to more than 100 frontline providers and hardworking individuals from across the country, and to discuss with them how virtual care and digital health were supporting the pandemic. The original idea was that we would do it during the third wave, which at the time I think we hoped would be the last wave, and then take the learnings and build forward. Of course, as you're all aware, that isn't what's happened. This report, therefore, was a moment in time, and what I've done today is to pick 5 of the key issues in the report and focus in on them to try to give you a sense of how those recommendations have continued to evolve during the 4th and now what looks like a 5th wave of the pandemic. I got a lot of people to thank, and so I've thanked them here on the slide. As some of you will know, I've been involved with InfoA pretty much since the beginning. I led the team that did the 2003 plan for the first 600 million, and I've been a commentator and a critic of InfoA's over the years, as well as doing some work on a couple of specific projects. So I will weave that in. I will also weave in ideas from some of my colleagues at Rotman, at C.D. Howe, at Women's College. I have been a serial investor in a number of the companies that I will mention today. I'm currently only invested in 2, or actively involved in 2, and then invested in a third one, AlayaCare. So I declare that. I'm also on the boards of my local community services agency and on the board of AMS Healthcare. Thanks as well to many other colleagues over the last several years. On the next slide, I've got a summary, just a couple of slides to talk about that report. As you would all know, in about a 2-week period in March of 2020, we cut over very quickly. And as Michael mentioned, I think he said 7 and 38%. We actually, went as high as 72, 77% in some provinces by April, May of 2020. We've come down somewhat since then. That was allowed because of some quick movement by the provinces and territories, which they should be very much credited for. And on the next slide, you can see the huge spike. These are Ontario data as published by Battier et al. You can pull the report if you want more detail on the QR code. Suffice it to say that virtual care has risen and dropped during the pandemic as we had higher and lower costs of physical contact. High costs of physical contact are infection control costs, travel costs. Infoway has estimated the baseline costs of a physician visit as being around about $100 in terms of travel, time off work for the average Canadian. In the pandemic, it was several times $100 because of infection control and other reasons. And that way of thinking of it is really important because it talks about financial and non-financial barriers that exist between physical and virtual care, and why you need to constantly be thinking about when you want to use physical versus virtual. On the next slide, I've got a summary, the next slide, we're going to talk about the 4 different ways that people looked at the pandemic. You'll see in the report that these 4 different ways were not mutually exclusive, but they allowed different people to have a different perspective. Now, I think there were very few people left who at this point still believe in the emergency life raft, that this is all just temporary. There are still quite a number of people who think that this is a time of experimentation and that we'll go back to something closer to normal. There are people who saw this as a stress test of IT systems, that we blew up a whole bunch of systems. And we go into some detail on this in the report. And then there's those who saw it as a radical shift to consumer-oriented healthcare. My own view is that the second, third, and fourth ones come in part that we get a lot of people learning a lot of stuff very quickly and continuing to learn as infection control regimes ramp up and ramp down. I personally think that's going to continue for quite some time, and that we're going to have to be smart about it. I'll leave it there for the moment. The next slide is my pivot slide in the presentation. Okay, one more, please. I'll come back to the market cap one. The pivot slide in the presentation, these are a summary of the 43 recommendations. This again, remembering please that this was at the time of wave 3. The report talked about the surprise of the dominance of the humble telephone, and I'll come back to that. It talked a lot about equity and about access, about user experience being worked through, and I think this is very much true today, that people are still trying to figure out how to improve user experience in their systems. On money, the question of payment will come back to the question of buying outcomes, not technology. There was a push to licensure changes that I hope has some legs and will continue. And overall, a conclusion that care is care, that virtual care and physical care need to be part of a multi-channel system here. Now, as I say, this is the pivot slide. So from here on in, what I'm going to do, and I start on the next slide, is to go through 5 issues that I thought would be most interesting to this group. And so what I'm doing here is I'm double clicking in on 5 topics that are covered in the report, and I'll leave the rest of the report for your reading. I'm going to talk about money. I'm going to talk about new change management approach. I'm going to talk about why we need to mandate digital information creation by 2023 as a patient safety issue. I'm going to talk about enforcement of interoperability standards and how that plays with an oligopolistic digital health market. And then I'm going to close by briefly touching on primary care. As I said, the report runs to about 35,000 words. It's available in both English and French. I hope you'll read the whole report, and I'll now pivot and go into the 5 key topics. On the next slide, I begin the discussion of money. A few things here. We introduced the idea of the principle of modality neutral funding. That is that wherever possible, and this may be like Michael's holy grail on interoperability, wherever possible, we need to not have the choice of modality being driven by the fee schedule. Clinicians and patients need to, between themselves, make the decision about whether a visit should be physical, whether it should be a text message or email, whether it should be phone or whether it should be video. By the way, those things may not actually be mutually exclusive. Those of you who, with your children or yourselves, use things like FaceTime, WhatsApp, Instagram, will all recognize that there's no actual difference between an audio feed and a video feed. They're both just electrons moving over a wire. And the audio feed has certain advantages because it requires less bandwidth. And so it is inherently more equitable for certain populations with certain configurations of systems. And so you're increasingly seeing things like clinicians using secure WhatsApp connections, starting on audio, and then flipping to video if and only if they need it. Now, if you happen to be a bureaucrat in the Ministry of Health writing remuneration rules, what I said is probably going to give you some gas pains or keep you up at night, because you were probably assuming that phone calls and video calls were different things, and they're not. And so you've got to change your mindset and think about how you're going to create modality neutral funding. That means using bundled funding. That means paying for basic provider-to-provider communications. It does mean you have to pay for asynchronous care. You cannot get away with ignoring secure messaging. And wherever possible, don't use fee-for-service. On the next slide, I make a point that I won't go into a lot of detail except to say at the highest level, it's important to remember that funding systems are not best practice systems. And this is hard for those of us in healthcare. We often assume that there's a best practice that we move to. Funding systems by their nature need to be changed and continue to change. Any system gets stale, any system can be gamed. Most systems can be gamed in a matter of weeks by very bright people with doctorates. So we need to really be humble as we create our funding systems and not think that we're going to make it all right once and be done with it. We're going to have to keep working at this, and we need to create an environment in which modality neutrality can be worked towards and moved forward with. On the next slide, I briefly touch on a couple of themes on this and different pieces. I'll just close on this topic and move to the next one by saying that all payment systems need clinical oversight. All payment systems have their flaws, and you need to have a way of having thoughtful clinical oversight to make sure that people are seeing patients when they need to physically and that there's balance in the system. Let's turn to some of the more technical issues that I know will be of importance to this group on the next slide. We've got change management and the new paradigm of change management. Now, you will all remember the original change management philosophy that was born in the same year that I was. So that's, old. The idea of innovators, early adopters, early majority, late majority. And, that isn't what happened during the pandemic. right? In the pandemic, on the next slide, instead of coming up to virtual care, we jumped to about 75% in most jurisdictions. Then we came down, then we jumped back up again, then we came down, and now we're going back up again. That means we need a different way of thinking about change management. All of your old change management theory, sorry, not all, that's an overstatement. Much of your old change management theory is premised on that gradual growth, which didn't happen. So what are you going to do? So here's what we suggest. Next slide. Go to a double baseline approach. The double baseline approach means, on the next slide, please, that when you look at a clinical delivery problem in 2022, you're going to have your 2019 standards of care, and you're going to have your pandemic 2021 standards of care. That double baseline is going to need to be looked at with some common sense, and you're going to need then to build upon that. On the next slide, we've got lots of examples where it's clear that we're not flipping back, right? Inflammatory bowel disease for peds. Mental health has been talked about at length. Pre and post-surgical bundles, where we've changed how the pre-admission testing or the post-surgical surveillance move. Congestive heart failure and endocrinology meds titration by phone, and how those, every specialty is different. There are some great academic groups out there working on some of these right now. Many of these have flipped and will not flip back. As my friend and colleague Sasha Bacha is fond of saying, it's not like we had a whole bunch of evidence for the prior system either in some of these areas as well. So we've got to bring some common sense to it, and then we need to do the deep clinical trials as we start locking in practice. Don't lock in practice too early. On the next slide, I turn to the question of how we build an interoperable system. And the first set of recommendations on this in the report is that I recommended that a set of services be only created digitally by April 1st, 2023. I'm going to back off a little bit and say that we should start in 2023, and yes, that is the year after next, with labs and drugs. I believe that we are at a point in the history of this enterprise of digital health where both labs and drugs have reached a tipping point, and where ministers of health can stand up and credibly say that all lab orders and results and all drug orders, usually called prescriptions, and results need to be created digitally as of April 1st, 2023. I also believe that as of April 1st, 2023, all electronic medical records in hospital and physician offices should be able to produce a usable digital summary that can be delivered to patients and be controlled by patients. This is a patient safety issue. Go to the next slide, please. This is now a patient safety issue, and I'm not going to point fingers here. I know that many people on the call will know some of the system failures of which I'm speaking, but there were a lot of system failures during the pandemic. And I think there's a forthcoming report in the next couple of days. It'll make some of this in a more academic way, make this point in a more academic way. But let me say this really clearly. Not creating these things digitally is a patient safety issue in 2021. It's an equity issue, and it's a quality of care issue. And we should not allow people to continue to create paper lab results and prescriptions. Okay. For those of you who think it's an overreach, we've got system vendors who are ready to do this. We've got Prescribe IT. And we also have a backup that we can put in place for a couple of years using QR codes, where we print where we print with a QR code that can then be uploaded in an EDI format. And that will allow us to move through the transition period and bring the laggards along, while at the same time making sure that we're ready for future waves and future pandemics. So yes, I'm calling on Minister Duclos and the provincial ministers to stand up and say, this is a patient safety issue and it needs to be addressed as such. We've paid for these services a number of times. Let's go to interoperability. Next slide, please. We had a plan. Michael talked about it. It's there, actually. The 2004 annual report's there. The EHR blueprint version 2 is there. You know, Dennis, Jose, the whole team, and teams that continue today under Mario and others. Some really, really smart people talking about stuff that I get a little bit lost in, and that's okay, but there was a plan. On the next slide, you'll see, though, that a funny thing happened on the way to the plan, which is that we had a bit of a who moved our cheese moment. We, people on this call, partners, Infoway, the government, everyone, we created a $20 billion industry in Canada. Point-click care is the #1 long-term care software in the world. AlayaCare is one of the top 4 vendors in the aging space. Dialogue. Anyway, there's a logo splash here, and I'm going to get myself in trouble by naming people, but there's a whole bunch of great companies here, and they've done great things. However, on the next slide, what we've done, and this is a 2-click slide, so be ready. You know, what we were building were systems of records. We conceived it as a records problem, but of course what's happened is that we're building now, as the second click comes through, a communication system. And that communication system involves phone, it involves text, email. And you know what? Like most of those big old record systems, they don't do that stuff, or they don't do it well, right? And so, you know, you've got Bob Wachter from the University of California in San Francisco complaining about Epic's secure messaging. I'm picking on Epic only because Epic is widely regarded as the best. And so how are we going to do secure messaging? When are they going to pick up their socks? And, you know, my friends over at TELUS bought Input Health because they recognize that that stuff's so important. That patient-focused stuff on the way in. So next slide. I'm going to go to the US for a second and then come back. On the hospital side, 80% of Canadian hospitals are one of the 4 US systems. Next slide. The US has promulgated now, they've been working on this for 10 years and they spent $38 billion to try to buy through meaningful use conformance. They have finally realized that they have to enforce the standards and have an enforcement mechanism. I propose that we skip over to enforcement immediately. I propose that we adopt and adapt the US standards. That will take some work. There's some great standards programs going. We got to adopt and adapt the US standards, and then we need an enforcement arm. Next slide, please. When we turn to the Canadian vendors, we know that there are 3 big vendors now. There's the grocery store, there's the phone company, and there's Li Ka-shing's company, Well, right? $3 billion companies. In Canada, we understand this, right? We've got 5, 6 banks, we've got 3 telcos. This is a regulatory issue now. This is not about funding more standards developments. Or sorry, let me say that differently. It is about funding more standards development, but it's funding standards that mean something. Because as many of you will know, it's easy to muck around with APIs. We need a fair play commission or committee that looks at APIs and says, is this a fair way that these people are playing? Next slide, please. And when someone tells you data is the new oil, You tell them that we don't want health information to go down the path that John D. Rockefeller took the oil fields in Pennsylvania and Texas. It's not the new oil. Data is the new commons. And we need to manage it as a commons problem, to manage and enforce standards much more aggressively in what are now oligopolistic markets. I'm going to touch very briefly on primary care, please, on the next slide, and then go to the closing slide. Primary care needs modernization. That's been shown during the pandemic. For those of you thinking about it, there's some models in the deck that I invite you to have a look at. Closing slide, please. I really thank you for taking the time today to listen to me. I'm happy to continue the conversation, and thank you very much to InfoWay for having me be part of this. And I hope that I've added some value as you begin your deliberations. Thank you.
Will, you obviously have done so much research, have a big heart for caring about this, and I'll certainly be watching for the effects of some of your ideas. A lot to digest. So maybe this is the perfect time for a bit of a pause, but applause to you. Thank you so much, Will, for being part of the conference today. So as we digest Will's presentation, we'll have a quick break. It will also give you a chance to check out the industry showcase, maybe top up your beverage as well. Our partners that have made this session possible and complimentary, by the way, for all attendees, are available to answer your questions and talk about developments in the industry. And you've just heard there are so many yet to come and so many that have been made already. After the industry showcase break, we'll move into those concurrent streams that I mentioned at the top of our conference. You will have 4 different streams to choose from. They're located in the north, south, east, and west rooms. So it's a good thing there weren't 5. Anyway, these session rooms can be found in the lobby or by navigating through the menu on the left side of the screen. And after each concurrent session, you'll have the opportunity to connect with your session presenters in the Connect Live rooms, where you can continue the conversation, because I know there will be a lot to talk about, and everybody's just got so much energy to do that because this is such an important topic. But before we head out to the break, here's a quick video from the break sponsor, Ontario MD.
Digital technology is transforming Canada's healthcare system in ways we couldn't have imagined. Ontario MD, known in the healthcare sector as OMD, is leading that transformation. OMD partners to help advance the products and services of other organizations that deliver value to practices. OMD connects to deliver quality digital health products and services for clinicians that make a difference to care delivery and patient outcomes.